I am Trevor Garcia. I'm a current National Chair of the Institute of Decontamination Sciences. I also work as an independent consultant as well. So, was a decontamination manager for 37 years in the NHS till 2019. And then I felt I'd done my time and needed to do the work that I enjoy doing within decontamination. And I also work with the National School of Healthcare Science in assessing apprentices and teaching apprentices. So this is around sustainability. Somebody did ask me when I arrived this morning what I was talking about, and the worrying bit was I forgot. I couldn't remember, I had to go look at the agenda. So these slides could be interesting to me. So, looking at some definitions, circular economy of medical devices. So we're looking at medical devices only. So it's a designing, procuring, I think design we all forget about, but designing, procuring and processing of medical products in a way that enables them to be reused, remanufactured or recycled, preserving their value as long as possible. And sustainability refers to the integration of environmentally, socially and economically responsible practices throughout the life cycle of medical devices. So they do work together. And we hear a lot around this. And then the linear supply chain, which is what we use a lot in SSD, is manufactured products that are used once and then discarded. So we've been talking about brushes for cleaning, for the endoscopy. We talk about in SSD the numerous disposable instruments that are used out on the wards and clinics, etc., which are used, thrown away, and repurchased. For those of you as old as me, not too many in the room, so we'll remember that in this will really show my age, late 70s, early 80s, we used to process nearly everything used in a ward or in a clinic was a reusable medical instrument. They weren't disposable. They didn't exist. So everything was processed. So are we looking at going back to the future? I think that was the CSE title, wasn't it? Yeah, rung a bell. But looking at five core components of sustainability, refuse. So that's don't use the device. If you don't need it, don't use it. Don't get it ready. I know AFPP, etc. will be shouting at me at this point. You can have it prepared, you can have it located near, but you don't open all these things and then find at the end of the procedure you don't use it. Or start looking at reusable equivalents, so we're going back again to where we were. My one word of caution is around when we're going back to using reusables, we need to be really careful which ones we select. We know there's challenges in decontamination of fine lumen devices, complex devices. We don't want to use those as disposable. We need to be very careful what we do. The second one is reduce, number of devices in the set. Briefly mentioned this morning. Again, look at what's in your set. How many instruments are in there that come back? How many SSD guys in here have had their staff coming at them, moaning, saying, oh, this set of 40-odd instruments, yet again, it's come back with 3 or 4 instruments used. Yeah? And as a manager, you have no answer for them, apart from trying to talk to the editor and say, can we make some sets up with these 4 core, knife, fork and spoon, your basic instruments, and have those available so that they have that as a choice and not open 40-odd instruments instead. Look at the number of open sets and say that's thinking about what you need. And look at reduce the number of fast tracks. Fast tracks are expensive environmentally, sustainability, etc. They are expensive to do and not a good plan. As I said, we need to change to reusable devices where available or create a market. We need to think that our whole, probably not quite our whole, a lot of our medical device market industry now is set upon disposable instruments. Loads of companies make disposable instruments. So if we suddenly say tomorrow we're not going to use them, what's going to happen to all those companies? What about the ones that make reusable? Are they going to be able to meet our needs? Forget about finance, forget about forwarding them or anything else. do we actually have the infrastructure for it? So we've got to have a complete change of mind in our marketplace. And we obviously have to look at financial advantages or changes. If we're going to go to reusable, then we're going to have capital available. We all know how available capital is. No. But we are spending it all on revenue. So somehow we have to have a way of converting revenue to capital. And some of that will be around the way NHS runs its finances. In the year end, everything stops and you start again. You've got to sometimes spend to save. We need to look at recycling, so we look at the waste of packaging, which we all know that's Amazon. You know, you get your little tiny widget that comes in about 4 boxes. So they need to look at that. They look at the instrumentation waste. Obviously, disposal's all thrown away. We don't look after the reusable instruments as much as we should, and I'll go on to that in a minute. And with some of our multiple part devices, it could be that some of them are designed so parts are replaceable, and parts can be recycled, so they don't all have to be thrown away and discarded. And going for renew, which is your last core component, is around repair budget. How many people got repair budgets here? 1. Good old Sharon. 2. 3. How many haven't? A few more. Yeah. Okay. So we used to have them. Why don't we have them now? We should be looking at refurbishing our instruments, which again was mentioned earlier. That will extend the lifespan of the device. And we can be looking at remanufacturing. And I'm not going to go too much into that, but particularly around limited life devices. When you think of the robotics, you have your number of lives use, throw it away. Should we look at what we should be doing with that better? So NHS produce 156,000 tonnes of clinical waste each year. So main actions they're planned is to design waste out, invest in recycling programs and reduce the use of single-use products. So also looking at the disposal and recycling, so end-of-life programs, so manufacturers to do a take-back program. Product life cycle tracking, so tracking a device's life cycle. Could be that some could be repurposed. And I'm just aware I've only got 20 minutes, so we also throw away an enormous amount of waste. I'm sure some of you have seen this wonderful picture, but looking at it in Leicester, anybody from Leicester? Right, so there's your total waste in the light green and the plastic waste in NHS. So we nearly we're only a little bit below Leicester in the amount of waste, which is sort of concerning, and the amount we actually recover is really a disaster. Environmental packaging, when we're looking at packaging, we need to look at trying to see if we can do some eco-friendly packaging. However, as some of you I'm sure are aware, packaging is now under new standards. There's new requirements, and when I was speaking to the Sterile Barrier Association, they're going to have to put more and more recycled materials into their packaging. And at the moment, they haven't all got the science to be able to do it yet. So we're asking them to achieve something that they actually don't know how they're going to achieve, which is slightly concerning. And they're saying it's probably about a 3 to 5 year life for them to get a design of a material out, tested, validated, and into use. So it's not going to happen tomorrow. But what they could do is look at reducing the amount of packaging. And then you can look at reusable containers. I think we mentioned earlier again, the containers may use more metals in the construction and everything else, but over its life cycle could be advantageous. So on reusable devices, there's an average of 38 to 56% decarbonisation compared to single use. Anybody wants to challenge me on that's fine, I have got it somewhere, but I can't remember where the reference was and I haven't referenced it, so apologies. Has anybody heard of the Design for Life project? Me? Okay. So it's been run by the Department of Health and Social Care. There's a policy paper that was issued in January 25, well, originally in October 24, January 25. It's been running for about 18 months or so. And in 2024 and January 25, they issued a roadmap. This is the way we are going to get medical devices along the right route for a circular economy, and it's all going to work. Okay? It is incorporating the people on that group. It's massive. There are people from manufacturers, decontamination people, BSI, standards groups, universities for doing the data crunching, and I can't remember all the rest. There's probably 100 in the room. But they have now produced a roadmap with 5 particular routes to go down. So this is around a plan to build a circular economy for medical technology to increase resilience, drive growth, realise cost savings, and improve sustainabilities. And it sets out the government's ambition to transition away from all avoidable single-use medical technology products towards a functioning circular system by 2045 that maximises reuse, remanufacture and recycling. So what we've got 20 years left. I won't be up here on the stage in 20 years. Sets out the way forward. Apologies, I've repeated myself there. Circular economy is well understood. It's increasingly, it's getting out there. It's being better understood. Not always rarely put into practice and difficult to scale. If we all do our own little thing, will that actually achieve what we want to do, or does it need to be a much more holistic approach? If it's too holistic and everybody doesn't join in, is it going to achieve what it's meant to? Probably not. We've got to properly hit a hybrid of it. Benefits, obviously opportunities for innovation and growth, improving patient care and value for money, supporting transition to net zero NHS. There are 6 identified problem statements with 30 actions to deliver, and I'm going to tell you every 30. No, I'm not. So the main things are leadership and alignment. What was out of all the meetings we had initially, it was very unclear direction and misaligned strategies across the value chain. I think probably most of us knew that, but it's written down now. There needs to be a behavioural change from all of us in the morning session regarding getting people how to change, how they disposed of waste and everything else. We know we're not so good at that. We need to find a commercial incentivation, just about get that out. So that the commercial side have got to be willing and can see that it is something that they can invest in. At the moment, as I said, you've got companies, whole companies just producing disposable instruments. If we stop using them, where do they go? What do they do? We've got to find something for them to do, or do it a different way. We've got to look at regulations and standards, physical and digital infrastructure, and transformative innovation. So that's around the digital side. On here, my drawing wasn't very good with my wibbly pen. Down here, number 20, for 2029, 2031, 4 years away to 6 years away, develop a decontamination infrastructure framework. So, it's the first time anybody's really thought about decontamination in this, so that was really good. So that's why I represent it, and a colleague from IDSC, we represent, and we're going to be leading with the DHSC on that framework. I've just had some lights flashing at me. I'm not quite sure which they mean, so I will go through a bit. So in the physical and digital infrastructure, decontamination in England, there is information that describes all available decontamination infrastructure with metrics such as location, ownership, specialisms, and spare capacity. No, there isn't. We have to work that out. Devolved nations, Wales, Scotland, Northern Ireland are much, much better at having that knowledge. England, because most of us are NHS trusts, we all work as an individual authority and therefore there is no sharing of information. So one of the first parts of this project is to actually identify where every decontamination unit is, what their capacity is, and work our way through there. Because at the moment, nobody can even tell me where every decontamination unit is. And what we're going to be looking at is seeing the way we work now. We won't be looking to just expand. We've got to look at different ways of delivering that decontamination service. How do? We don't want to bring, I mean, the guys with SSD in here, how much capacity have you got? Spare 50%? 20%? 5%? None? Anybody got any spare capacity? Okay. So we can't say to you, with your 8-year-old machines, you're now going to open 24/7 if you're not already, and you're going to do 30% more work because your equipment will fail, won't have staffing, won't be funded. Even if we did do the staffing and the funding, it's still, the machines won't work for long. So we need to find another way of doing it. We've also previously mentioned again was the move to linen. John and I had a little conversation about that earlier. We've got to consider it at the moment. I think we have to be fair. We've got to consider everything and work our way through what makes sense, what doesn't make sense. And that's the one thing, at least with, hopefully with some decontamination in this national group, they have listened to us so far. That's why that 2029-31, it's happened that we're starting to do the work on it now. So we've brought that forward 4 years, which is quite impressive. So they've now realised it is essential. And there's some key people in that group of people who are very much supportive of decontamination. So we will get our fair 10 pennies worth in. Obviously with linear products, with disposable, they're easily available, and you go to the shelf, grab them, use them, chuck them. Easy. Multiple suppliers, so you can easily get them. Ease of use and disposal. No segregation tasks for differing waste streams. Well, perhaps there should be, but we're not great on that, and no drive for change. So we need to develop a training and skill. The other thing is, if we are going to change all our clinical colleagues and say to them, you're not going to be using single-use equipment now, you're going to be reusable. What are they going to do the first time they use the set? Chuck it away. Okay? So there's got to be a large educational and training framework set up and really put out. Happens in, I don't know if any of you do community midwives. They're really good at throwing away all the reusable maternity and suturing packs. How fantastic. They could lose 100 in a couple of weeks. They're all in the back of my sister-in-law's car. And we've got to deliver targeted resources to support self-care. We've got to look at, again, with the commercial incentivisation, I think I've covered that. We need to look at the manufacture of medical devices built to last longer. I'm not sure if that's the right word, but make sure they're repaired. They're repairable, they're refurbishable, possibly made with modular components so you don't have to replace the whole device. Maybe you can just replace some of it. And look at decontamination in the design stage. The light's gone red now, so I'm definitely running out of time. The worst bit is I don't know how many more I've got. Standards, we've talked about that this morning. I made the comment this morning in the, or afternoon, whichever it was, this morning's session. There's new innovations out there. We need to embrace them. We need to look at them. We need to make sure that we can work with them and get them in safely. And we need to have some guidance on that, I believe. Regulations and standards are involved in this group as well, so it is being looked at. There's something like about 80 sustainable standards, ISO standards out there. It's a ridiculous amount. But nobody knew, when we were on the group trying to look at them, we didn't know there were that many. Of Cool. That driving thing in the UK, driving a domestic market for local re-roof, driving UK growth. God, who do I sound like? Reducing environmental impact, we all know we've got to reduce that. And we've got to look at saving money for the NHS. So in summary, we need to think about the way we work. We need to perhaps change the way we work in some things. Look at more reusable devices. Reusable, recyclable, sterile barrier systems. Nothing wrong with a disposable barrier system if it can be recycled and used for something else. We do need to remember there is a limited market for the bottom end of things that have been recycled many times. Further investment to meet the objectives. Manufacturers, if we don't work with them, we're not going to achieve change. And single use, not as a go-to, not as a standard. We need to think about that. So, the most environmentally friendly product is the one you didn't buy. I think that's fine. We're using resources. We had 2 planets, not 1. There can be no plan B because there is no planet B, etc. Okay, thank you.